Okay, I think I'm going to get going with just a little introduction and my opening spiel as more people kind of join in. But welcome, good morning, afternoon, depending on where you guys are. It's nice to see everyone here this morning, and I really appreciate being able to present for you today. My name is Stephanie Magnan. I am the program director for the Geriatric subspecialty program at the University of Alberta in Edmonton. And I asked actually to talk today because this area of palliative care and dementia is one that I've really developed an interest in and a passion for over my time in clinical practice. And it's an area that I felt grossly underprepared for as I finished my residency in dealing with sort of the realities of what I would have to manage looking after patients with severe advanced dementia in the hospital. So that's kind of where I'm coming to you from today. I'm going to fiddle with my technology because even after 5 years or 6 of using Zoom, I still am not great at it. So let me do this. All right, does that look reasonable? Okay. All right.
Yes, that works.
Thank you, guys. So I'm going to chat at you today. I haven't given this talk in a little while, so I may start rambling. What I'm hoping is that, I really want to present to you a very clinically focused, practical talk on the palliative care needs of patients with advanced neurocognitive disorders. And I'm going to share this with you from my perspective. So I have no sort of financial speaker relationships. I really have gotten all of the training that I have in palliative care kind of after residency by doing additional kind of courses, conferences. But I'm not, a palliative care physician. I'm not a family doctor. So I'm really coming at you as a psychiatrist in how I manage these things. But, there are experts out there who really, if you get into trouble or if you get overwhelmed with this patient population, please don't hesitate to reach out to them. And I do all the time just for their help and perspective. So in terms of learning objectives for today, what I'm really hoping, like I said, is to kind of keep things very clinically focused and fairly basic. I really want everyone here to come out of this with a comfort level of being able to explain to patients, family members in particular, how dementia is unfortunately a terminal illness and would benefit from a palliative approach to care. I'm going to talk a little bit about the complexities of providing palliative care to this patient population and talk through the benefits of a palliative approach throughout the diagnosis, and particularly in terms of pain and symptom management at the end of life. Because for us here in Edmonton, our main geriatric psychiatry hospital, 2 of our units are secure units for patients with end-stage advanced dementia with severe PTSD. And unfortunately, we look after a lot of patients who ultimately have their last days here. And so I really sort of, as an attending psychiatrist, have needed to develop a comfort level in managing those symptoms myself, as well as sort of knowing how to assess them and, when to call for help. So we'll go through all of that today. Please feel free to jump in with questions or comments as I'm talking. Otherwise, I'm going to try to do my best to leave some time for questions. I'm moderating myself, which is always a challenge. So we'll do our best to have a little bit of time to chat at the end as well. So I think in this group here, we're all definitely going to be on the same page when I'm talking about dementia. So dementia, or major neurocognitive disorder, as we refer to it in our DSM, is a neurodegenerative process where a patient experiences a cognitive and a functional decline from their previous baseline. And that decline initially presents usually in 1 or 2 of the following cognitive domains. And ultimately, as the disease progresses, all of these domains are generally impacted. When I talk to patients, though, and their families, and I use the word dementia, people aren't necessarily thinking all of the same thing. And so when I talk to, my family's, basically I explained that dementia is really an umbrella term for a number of different illnesses and disease processes. And ultimately, what dementia reflects is the disease of brain failure. And using that term with families, I've really found helps to give them the perspective that this is an illness of the brain as well as the body, not just of the mind, and that it is an illness that unfortunately, like heart failure or kidney failure, is going to be progressive, is going to impact a person's function and quality of life, and ultimately is a terminal illness. And that is not something that a lot of people necessarily understand at the beginning of the diagnosis. Certainly they know that Alzheimer's disease, dementia, is not a good prognosis, but a lot of people really do kind of focus on the memory component and kind of forget the physical toll and ultimately, the toll that this will take on the patient and their family. So just going over a couple of statistics, and again, I think you guys will be mostly familiar with this, but when you go to kind of the Alzheimer's Society website or any sort of Canadian data source, the numbers are alarming and are only increasing. And so none of us really will ever be out of a job. This is a problem that is only going to get bigger. This is a patient population that is only going to grow as people are living longer. So as of January 1st, 2025, the estimate is that over 700,000 people in Canada are currently living with dementia. Looking at the statistics over a 10-year span from 2020 to 2030, the expectation is that the number of people living with dementia will increase by 65%, and that a total of 6.3 million people in Canada will develop, live with, and or ultimately die with dementia between 2020 and 2050. So this is a massive public health issue, and this is an issue that we obviously all are going to be working with and managing in our clinical practice moving forward. Early onset dementia presents its own distinct challenges, and often there are issues with sort of inaccurate and delayed diagnoses for this condition, as we all know very well. By 2050, the estimate is that there could be over 40,000 people under the age of 65 living with dementia in Canada, up from an estimated 28,000 in 2020. And this is a population that's particularly difficult to work with, to find resources for in the community, and it's only going to grow. So when you're looking at the prognosis and the course of dementia, again, knowing that this reflects a number of different underlying processes, it can be very broad. And so the disease can progress over anywhere from a couple to up to 20 years in some slow progressing forms. The average life expectancy, again, depending on the diagnosis, is highly variable. On average, they say about 7 to 10 years from diagnosis. This is predominantly for the Alzheimer's or mixed vascular type. Some of the other dementias, particularly Lewy body dementia, tends to have a shorter prognosis overall. But again, averages, explaining things to family, that's generally kind of what I will explain to them. When we look at the burden of care, so this is a figure from the World Health Organization, looking at the worldwide need for palliative care for adults over the age of 18 by different disease groups. And dementia is only growing. So when you looked at this figure in 2014, dementia reflected only about 2% of the global burden of palliative care. And by 2017, and this actually figure was published in 2020, that had gone up to 12%, and it was one of the major sort of progressive diseases that was requiring palliative care intervention. So again, looking at the numbers, looking at the statistics, this is only going to grow more. And it's unfortunately an area that a lot of physicians still don't have a lot of dedicated teaching or experience with. So it's a very underserved area overall. So I'm going to present a few different figures here. This is what I really like looking at in terms of Alzheimer's disease, just to illustrate again to patients and families kind of the natural history of how things progress. And this one actually looks based on cognition and the MMSE score. So when you start with an MMSE score of around 28 to 30 out of 30, Generally, symptoms will start to develop but can be fairly mild and vague. The time of diagnosis usually isn't for at least a year or two after symptom onset. And then as things progress, we start to see the more global sequelae. So we start to see that loss of functional independence. We start to see BPSD and behavioral problems. Really, those can occur at any point over the span of the diagnosis, again, as we all know very well. And towards the end, as the functional decline and cognitive decline progress, patients need increased levels of supports. They end up often placed in nursing home facilities, and ultimately they do pass away from this disease. And that is something actually that families often don't have a great concept of, is how people pass away related to their dementia. So one of the really difficult things in sort of talking about palliative care and determining sort of when to initiate a palliative approach, gauging when dementia sort of hits a point where we're starting to talk about late stages and end of life, people kind of explain or assess progression in different ways. So one of the ways is based on the cognitive progression and the cognitive decline, and this is one of the scales that we use to assess cognitive stages of dementia, called the Global Deterioration Scale. Again, something I think you'll all be familiar with, but this is just a nice figure that would illustrate it and give some examples of sort of what patients will struggle with at any of the given stages. By the time you get to sort of moderate, severe, or very severe cognitive decline, you're really starting to see profound functional impacts as well. And when you're in the severe and very severe stages, at that point, your basic activities of daily living are starting to be impacted. There's often issues with incontinence. There's sort of basic drives that start to be impacted. So the sleep cycles start to be impacted. Orientation, hunger, thirst can start to be impacted. And by the time you get very severe, at that point, you start to have issues with swallowing, mobility, intake, bowel bladder control, and you really are fully dependent and reliant for care. By the time folks get to our advanced dementia units, they tend to be in that 5, 6, 7 cognitive stage, and they're being referred to us to manage their BPSD. Ultimately, a lot of those BPSDs really reflect sort of unmet needs and that really rapid functional decline. So here's another way to sort of look at disease progression, and that's based on the functional impact. So this is the functional assessment staging test, and again, 7 stages here, looking at the particular level of assistance that patients are needing. And again, by the time they're coming to us, absolutely within that 5, probably 6 or 7 stage when we're managing them as inpatients at our facility. And so this is the patient population I'm really going to be focusing on today. And then finally, assessing disease progression based on frailty. And the clinical frailty scale developed out of Dalhousie University is one of my favorites to show to families to really illustrate how this disease has a full body impact. This really brings the cognition and the function together and illustrates, especially for those early onset patients who can still be very physically robust and healthy, how they are in fact frail. And how this illness is really impacting them to a point where, their body, although it looks healthy, is extremely vulnerable. And it helps really to explain, again, the prognosis that we're dealing with and the rationale for starting to focus on comfort rather than cure and symptom management. So that really brings me to kind of the discussion piece of where I meet families for the first time when they're bringing a patient onto our unit. In 2009, there was a foundational article published that got a lot of media attention around dementia as a terminal illness. So this is a screenshot from Time magazine in 2009. And this was really, I think, a lot of people's first sort of exposure to dementia as a palliative terminal condition. And it was really, I think, one of the quotes that stuck with me and is how, again, I kind of communicate this to patients. is this one, where dementia is most often thought of as a memory disorder and an illness of the aging mind. In its initial stages, that may be true. Memory loss is an early hallmark of many types of dementia. But experts in the field say dementia is more accurately defined as fatal brain failure, a terminal disease like cancer that physically kills patients, not simply a mental ailment that accompanies older age. And that was sort of a light bulb moment, I think, for a lot of people. And I think really kind of pushed some of the issues that we're talking about into kind of the public eye. So this is the article here in the New England Journal of Medicine, October 2009 by Mitchell et al. And it was using data from a cohort study to look at patients with severely advanced dementia over a period of 18 months. And it was looking at the physical complications that they developed, as well as the end-of-life care that they received. And it looked also at the family decision-maker caregivers' understanding of sort of the course and prognosis of dementia through this process. So in terms of physical complications, the most common physical complications that were identified in the advanced stages of dementia were pneumonia, febrile episodes, and eating problems. In at least half, if not 86%, were experiencing problems with dysphagia, feeding, and swallowing. All of these complications, when they were to develop, were associated with a very high 6-month mortality rate, so up to 40 to 45% risk of mortality in the next 6 months when they had one of these physical issues. They noted that pain, agitation, and dyspnea were the common distressing symptoms that patients were experiencing at the end of life. And they noted that in the last 3 months of their life, 40.7% of these patients underwent at least one burdensome intervention, whether that was hospitalization, an emergency room visit, parenteral therapy, or tube feeding. However, they commented that patients whose decision makers had an understanding of the clinical course and prognosis were less likely to receive invasive and aggressive interventions near the end of life. And it really reinforced the importance of patient-focused care for this population, emphasizing comfort, symptom management, and dignity. So again, when I talk to families, I really stress that dementia is not only an illness of the mind, but also an illness of the whole body. The brain is the computer that runs the functioning of the body, and there is a physical toll as that brain begins to fail. So dementia is a physical illness, a degenerative terminal disease that shuts down the body as it attacks the brain. And the lack of understanding of this does mean that many patients near the end of life are subjected to aggressive treatments that would never be considered with another terminal illness, such as an advanced cancer patient. And again, a number of quotes from the article that really illustrate this process. And at the very end, very clearly, they state dementia is a terminal illness. And that is an illness that will benefit from palliative care. So what is palliative care? Traditionally, palliative care, and a lot of people still kind of associate this, palliative care has been equated with end-of-life care. So you get a diagnosis, that is a terminal diagnosis, dementia, cancer, organ failure, whatever. You undergo a period of life-prolonging or curative treatment, and then at a certain point, that treatment no longer works. You start getting palliative care, and then you die. That's kind of people's understanding often of the palliative care process and involvement. In reality, palliative care is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. Its purpose is to relieve suffering through early identification, correct assessment, and treatment of pain and other problems, physical, psychosocial, or spiritual. So it really is a broader approach, and one that is not necessarily only applicable at the end of life, as we're going to talk about. So the challenges for palliative care in dementia, there's a number of them. These are just a few. One of the big ones is that as the process advances, it inevitably impacts the patient's ability to communicate and to express their symptoms. And so that really complicates management. It leads to under-recognition and under-treatment of distressing symptoms, particularly pain. In terms of ethical considerations, there's decisions about things like artificial nutrition and decisions that have to be made about resuscitation, and those can be very challenging. The patients can no longer necessarily express their preferences, and caregivers have a really hard time making these decisions on behalf of their loved ones. Stress and emotion come into it, and this can lead to conflict within families. This can lead to conflict with the care team, and it's a very challenging situation sometimes to run into in this group. We also talked a little bit about systemic barriers and access. Palliative care programs, are out there, but there are often limited access issues, particularly to patients in rural areas. And there are still many healthcare providers who have limited training in dementia care specifically and the palliative needs. And then, as we kind of alluded to as well, the course and trajectory of dementia is really variable depending on the underlying illness, the patient's other comorbidities, their age, etc. So how do we know when the end of life is imminent, and when do we start a palliative approach? So the big kind of question that patients and families often ask me when they come in to the hospital here is sort of, at what point are we kind of talking about the patient actively dying? At what point does dementia become a palliative condition? And really, there are different, again, approaches and philosophies to this. When should we trigger a palliative approach? So obviously, based on patient or family choice or need. So if the family explicitly asks for and chooses comfort care, we would definitely sort of be implementing those strategies. One of the questions in palliative circles is the surprise question. So you ask yourself, would you be surprised if this person were to die in the next 12 months? If the answer is no, you should probably be implementing some palliative care strategies. Do you implement based on clinical indicators? So are there factors already present which suggest that the disease is quite advanced or towards the end stages? So based on some of those scales we looked at earlier, are they in that kind of 6, 7, 8, 9 stage on the clinical frailty scale? Are they kind of in that 7 stage on the FAST scale? Really, what I'm hoping to impart to you today is that the right time to trigger a palliative care approach in dementia is right at the time of diagnosis. And for those of you who are going to be working in outpatient settings, who are going to be delivering new diagnoses of dementia, this is an area where you can really have a profound impact on the patient's trajectory towards the end of life. So here's just another illustration, again, of different kind of end-of-life trajectories. Some of them, it becomes very clear when you start to implement palliative care. So trajectory number 1 is kind of the typical cancer trajectory. You get a diagnosis, you get active treatment, and at one point that treatment is no longer working and you start more of a palliative approach. Yes, Shannon.
Do you have a way of sort of getting a team on board with a palliative approach? Because I've suggested it for a number of patients. Everyone's like, no, they're not dying yet. And I don't seem to be getting over that sort of that threshold of getting buy-in from the rest of the team to initiate that phase.
Yeah, it takes time, right? And we're very lucky here because I think our team is really comfortable and familiar now with this patient population and in managing it. In a lot of places, it's not geriatric psychiatrists who are the primary attending physicians, or it's not on a geriatric psychiatry unit where these patients will end up. They're on medical units. And the goal of a medical unit is to treat people and fix people. And a lot of people are really uncomfortable with not being able to fix things. And so a lot of it comes down to education and talking about frailty and talking about dementia as brain failure. And those words, to me, I really find bring it home to people. But this is organ failure like any other organ failure. If you have end-stage heart failure, that is a palliative condition. If you have end-stage brain failure, that is also a palliative condition. The body cannot survive without the brain. And so if we're getting to the point where a patient is having recurrent aspirations, they're not able to eat and drink enough to keep their body going, they're in pain, they're in distress, they're agitated, and you're not able to settle that delirium, that is a sign that the brain is no longer at a point where it's able to keep the body alive. And I find using those kind of blunt terms really can be helpful in kind of shifting the perspective. So that's kind of my best advice. But it's a process that takes time, and it can be challenging. And that's where if patients and families especially understand this from early on, they can help be advocates as well, and they can have appropriate goals of care at these stages. And it's really, beneficial. You're not the one doing all of it. There are some indications, again, these are guidelines from the National Hospice Organization in the US around when dementia patients may qualify for hospice. So typically hospice has generally a 3 to 6 month prognosis. And so the guidelines that they use that functional assessment staging tool, the FAST tool, and they look at patients being beyond stage 7C, where they're unable to ambulate independently, really essentially bedbound, can't sit up, can't smile, can't hold head up independently. So they must be kind of, and they have to have all the features of stage 6A as well. So can't dress, bathe. So all the ADLs have to be gone. They have to be incontinent. Their communication also has to be impacted. And they must have had at least one of the following in the past year: aspiration pneumonia, pyelonephritis, septicemia, pressure ulcers, recurrent fever, or eating problems. And that goes back to that 2009 article that showed that those issues were associated with a very poor 6-month prognosis. So this is really what palliative care should look like. So early, at the time of diagnosis, there tends to be more of a focus on disease-modifying therapy or curative therapy. You might try a cholinesterase inhibitor to slow things down. You might be kind of implementing more active management, working on things like goals of care, putting OT into place, physio, those sorts of things, restorative, rehabilitative treatment. But you also want to start having some of these conversations early. And there are some palliative approaches that you do early on in the disease that can really make a difference. As the disease progresses, that balance starts to shift. So you start to incorporate more palliative care symptom management, and there's less of that disease-modifying, restorative, curative treatment. And ultimately, at the point of death, ideally, things shouldn't end. And there's actually a period of support for the family as well. Through bereavement. And true palliative care programs do incorporate this as well, sort of post-death bereavement supports for families and caregivers. So in terms of early disease, so when we go back, at this point here, some of the early palliative interventions that you can implement that really have a profound impact. Number one is psychoeducation. So again, going back to that article, families that were aware and understanding of the disease itself and the prognosis had better outcomes. So one of the techniques that is taught around giving difficult feedback is the ask, tell, ask technique. Where you ask them what their understanding is of the illness, you explain a little bit to them, and you ask again, what have you learned? Do you have any other questions? And kind of facilitate a conversation that way. So talking about patients' values. What do you know about your illness? What are you afraid of? What is kind of the worst case scenario for you? What kind of management would you want as this disease gets more severe? Talking through goals of care, doing advanced planning is extremely important, especially at a stage where a patient can actually still voice this for themselves in front of the family who are going to be their caregivers, so that that family later on, when these things start to become issues, can feel confident that they're making the decision that the patient would want. I've summarized a few kind of core components of the goals of care conversation. Again, I think everyone here is going to be pretty comfortable with having these kind of difficult conversations with families. The Alberta Health Services kind of goals of care document tool, which I've summarized at the end, has sort of some good examples of phrases to use, conversations to have with patients if you want to have a look at it. But really, core components: you prepare yourself, you review charts, you ensure that you're in a suitable setting, you figure out who the substitute decision maker may be and have them there with you, assess the understanding of the patient and family, gauge how much they want to know, because they may not be ready for that conversation yet, but plant the seed that this is a conversation that you would want to have and continue to bring it up until they're ready. Identify the patient's values and goals, discuss their prognosis and the limits of care, especially toward the end of the disease, and start making a plan. In patients with significant enough early memory impairments, you may have to have this conversation a few times, repeat it, ensure sort of consistent understanding and consistency in their responses as well. If the disease has already progressed to a point where there might be questions about some of the medical decision-making capacity. The other big thing that you can look at as a physician is deprescribing. So polypharmacy, declining organ function, malnutrition, cachexia, changes in body composition as the disease progresses, increased frailty, all increase the risk of drug-related problems. People start to develop issues with swallowing, they start to lose insight, and feel that they don't need medications anymore, and it starts to get more difficult to get them to take them. So being sure that you're reviewing their medications regularly, sort of through a lens of where they're at in their disease, carefully considering the remaining life expectancy, the expected benefits of the medication, the patient's goals of care, and the treatment targets for each drug. So common things that you can start deprescribing sort of earlier, things like vitamins and supplements. You really want to look at risks versus benefits of things like anticoagulants and aspirin, especially when a patient gets more frail, starts to develop more mobility issues, starts to fall. Things like anti-hyperglycemics and having too tight glycemic control, especially if eating and nutrition start to change. Antihypertensives, statins. Those are sort of things that have long-term protective benefit, but when the patient doesn't have a long prognosis, there are also significant side effects to these medications. And so you want to kind of weigh whether it's still something that's having significant benefit to them. And finally, our medications, acetylcholinesterase inhibitors, Magnan, all of the psychotropics that we're using, you want to periodically reevaluate what is this being used for, what are we trying to treat, what are the side effects that they're having, if any, and is this continuing to have benefit or not. There are structured tools that you can use for this. I did cite one of them at the end of the presentation as well. I talk with pharmacists all the time about this. I'll talk with the family doctors as well and kind of go back and forth, on some of the medical things, the antihypertensive, the antihyperglycemics, talk about what our targets are. But this is a really key sort of comfort care focused intervention that should be happening all along the disease course. So timeline, they're not too bad. So we're getting to the point where I want to really talk about the end of life, the clinical assessment and the management of the actively dying patient. And this is something that not all of you will do as part of your clinical practice. I do think we're pretty unique here in Alberta, and I'd be curious to hear from some of you later about kind of the patient populations that you guys have on your geriatric psychiatry inpatient units. But I think in a lot of places, the patients with the end-stage dementias are managed on family medicine, internal medicine, neurology units, with us primarily as consultants. For us, though, we have 60 patients in our hospital here on our advanced dementia units with these end-stage illnesses, and we do end up being the attending physicians managing end-of-life care in certain cases. So common end-of-life distressing symptoms that need to be appropriately managed in these patients include these domains. So dysphagia, feeding and swallowing issues, constipation or diarrhea, really common and can be very distressing, nausea, vomiting, dehydration or edema, dyspnea, agitation and anxiety, and then pain. And so I'll talk through each of these in a little bit more detail. And hopefully at least give you a starting point to be able to have an approach to these symptoms initially. And like I said, at a certain point, this does kind of get out of our scope and out of our depth potentially. And that's where you always want to kind of recognize the point where you want to bring in a palliative care specialist to sort of help guide your management as well. And I've done that for sure on a few occasions. So dysphagia. So we saw from that 2009 trial, 85% of patients in those end stages of dementia would have issues with feeding and swallowing. So number one, you want to educate them. Hunger, thirst, these are drives produced by the brain. Patients may not have the same appetite they used to have. They may not have the same interest in food they used to have. And the eating process is one that actually also takes a lot of brain power and coordination. Coordinating, chewing, swallowing appropriately, muscle tone, sedation, all of these things can have a big impact on a patient's ability to eat adequately to keep their body going. These issues are often multifactorial. They're not easy to fix. So they can include issues with just apraxia, muscle discoordination, poor alertness, attention. And we also see altered metabolism with sort of a chronic neurodegenerative illness, where we see physically muscle wasting in protective patients looking increasingly physically frail towards those end stages often. We also see patients here, particularly with acute behavioral disturbances, persistent agitation, restlessness, and they burn a ton of calories. So even patients just kind of sitting there, sort of jiggling one of their legs all day, every day, that burns a ton of calories. And so even if their intake looks normal, we often still see people losing weight and not able to take in enough calories to kind of maintain that level of caloric deficit. Feeding can still remain pleasurable. Food can provide comfort. And so if a patient is alert and interested, it's important to have conversations about that even if they're struggling to eat and drink, if they're still hungry, if they're still enjoying food, if families are still sitting with them to have a meal, that is something that, can be important to continue. And don't forget about proper mouth care. And obviously patients are fully dependent, usually at this point, for their ADLs. And mouth care can be something that's sort of easily left aside. But poor dentition, can be very painful. It can really impact swallowing. It can increase your risk for aspiration pneumonia. So it's a really, really important piece of things as well. This is often very distressing for families. They see food as medicine. They don't want their family member to starve to death. And so there are some times where conversations do come up about artificial nutrition and feeding tubes. And that again is where sort of having an understanding and being able to educate people is really important. And the reality is that all of the evidence shows that feeding tubes in this population do not help. They do not prolong life. They do not actually decrease the risk of aspiration. And ultimately, they are not a recommended tool in this patient population. Patients are agitated, they're restless, they'll pull them, they have to be restrained to keep them in place. It can be a very, very distressing intervention and ultimately does not typically prolong life significantly in all of the studies that they show. So again, talking about feeding at risk, talking about, when the patient is still alert and interested, if families want to visit, they want to bring some of their favorite foods, things that may appeal, talking about the risks of sort of choking aspiration versus the benefit that it brings to them in terms of their quality of life. Can be a really important conversation. Constipation, quickly, very common, often missed. The patient can't complain of it unless someone's kind of documenting and monitoring. It can be one that's easily missed, but can have a great impact on a patient's comfort level and quality of life. It can cause a decrease in appetite, decrease in nutrition, which can then lead to dehydration, can lead to delirium. It can be uncomfortable, it can lead to confusion, agitation. If you're at a point in the illness where you're using opioids for dyspnea or pain, 100% of those patients are going to get constipated, so make sure they're on a laxative. That's my number one message. When you're looking at patients at the end of life, you really want to avoid the kind of bulk forming, really kind of fiber heavy laxatives, as their hydration is often decreased as well, and that can actually make the problem worse. So you actually want to use things like stimulants, osmotic agents, lubricants, primarily as your laxative treatment. Urinary retention is also relatively common, again, can be worsened by constipation. So that's another thing in those really late stages that needs to be kind of monitored. And often in those patients that are in the last days of life that end up bedbound, we may need a fluid catheter as well to help them drain the bladder. Nausea and vomiting, so that is a symptom of some underlying cause. So you want to figure out what's causing it. Is there an infection going on? Is there pain? Is there constipation? I don't see this as much as a symptom in our older adults here, unless the constipation isn't addressed, and then we see it all the time. If you are going to use antiemetics, that can be challenging. There's lots of side effects to these types of medications. There's sedation, obviously, confusion, anticholinergic delirium if you're using things like Gravol. If you're using things like metoclopramide, you need to watch out for extrapyramidal side effects in patients who are also on antipsychotics or who have been very vulnerable to EPS. And we'll look for things like serotonin syndrome. QTC prolongation is not as big of an issue at the end of life that you're worried about imminently, but I mean, you want to sort of have it at the back of your mind. If you have a patient on a number of serotonergic agents or QT prolonging agents, maybe that's not the best choice of an antiemetic. So kind of sort of thinking through your treatment in a patient-centered way based on how they're presenting. And don't forget actually the potential of your psychotropic medications as antiemetics. A lot of the medications that we use actually do have anti-nausea properties, things like olanzapine, haloperidol, mirtazapine, all have good evidence for managing nausea as well. So you can kind of harness the effects of that if need be. All right, dehydration. So this again can be a challenging thing to discuss with families. If patient is no longer eating or drinking, should we be considering hydration? We know that the body functions are not normal at the end of life. That sensation of hunger and thirst is not like we perceive. So it's not like the patient is, feeling like they're in a desert and they're parched and they need a drink. That cue is probably no longer there for them. And if we are kind of giving parenteral hydration, there's often issues with malabsorption, high rates of cooling, peripheral edema. So you want to talk with families about the pros and the cons. The pros, it can help improve alertness, reduce confusion, reduce constipation, but you may need physical restraints if you're trying to keep an IV in. You may have issues with discomfort or cooling. You may have issues with pulmonary edema and respiratory congestion. And it is likely to prolong those last days of life as well. So having those conversations with families is also really important. Dyspnea in the very last hours to days of life is often observed. It can be in multiple etiologies. When you're looking at managing dyspnea, you're not looking at kind of maintaining SATs above 92. You're not getting a ton of, high flow oxygen because that can be very uncomfortable. We often won't use oxygen at all. We'll put a fan by the bed that kind of moves air, and that can improve that feeling of airflow and air hunger. You can do positioning, suctioning. Opioids are a really key tool if the patient is in respiratory distress to kind of slow and deepen the respirations. You can use anxiolytics. And a lot of them is just about educating the families as well that this is a normal physiologic response at the end of life. Things like chain Stokes breathing, where a patient will have rapid breathing for a period of time and then periods of apnea as well in those last couple of days. If the family knows to expect that, they won't be quite so shocked and distressed by it. Agitation and anxiety, you guys are going to be good at that. So antipsychotic medications are really first line. Usually patients are unable to swallow at this point. In the palliative care circles, they use a ton of methyltrimethazine or Magnan, the old kind of first generation low potency antipsychotic that has a lot of sedation, a lot of side effects, but is really effective actually for these folks for agitation. We'll also use loxapine, Haldol. Palliative physicians are also starting to use a bit of olanzapine sub-Q. I'm not the biggest fan of that. I haven't seen it to be as effective as the other options, but just bringing it up because it is out there in circles and it is kind of being used. I love Magnan. That's my go-to. Benzodiazepines can also be useful, just keeping in mind, obviously, the higher potential for delirium, confusion, and if you have a patient on opioids as well, that risk of delirium and the risk of respiratory depression increase exponentially if you're using both. So just being very cautious. And running low on time, the last bit though is pain. Again, the key thing for pain is that really once you hit sort of a cognitive level, a mini mental score below kind of that high teens, patients' reliability in being able to express and communicate pain is very poor. Pain is a construct of the nervous system, it's a construct of the brain. And so patients don't necessarily experience pain in the same ways that they used to, and they can't necessarily express it verbally, but you will see it in other ways. And so very often my first intervention for a patient that's showing up on our advanced dementia unit with agitation, restlessness, irritability is to put them on Tylenol around the clock. Because my assumption is there is some pain there that they are not able to report. Most patients in their 70s, 80s, who've had a long life, who've worked hard, have some degree of arthritis, they're restless, they're agitated, they're constantly moving, they're falling, they're going to have pain. So make sure that you're assessing regularly and managing pain adequately. And there's many sort of scales that you can use. Lots of them are validated. It doesn't really matter which one you use, just use one and monitor it regularly. There's different ways to approach it. You want to consider non-pharmacological interventions as well, making sure, the patient is repositioned regularly if they're bed bound, looking at wounds and skin integrity, massage, music, those kinds of things. Generally start with non-opioid medications, around the clock Tylenol for everyone, I say. Look at neuropathic pain. Cannabinoids are being used increasingly for pain as well as agitation. They can help with nausea. So again, depending on the clinical picture, looking at non-opioid options while a patient is still able to swallow can be helpful. When you get into those later stages, often we're getting into the need for parenteral medications, subcutaneous territory. And usually we're using morphine or hydromorphone. Hydromorphone is my number one go-to. It's cleaner. It tends to be a little bit better tolerated. And if opioids are used properly, they do not shorten life. And that's another myth that sometimes families need to be educated about, is that if you are using these appropriately to manage symptoms, they do not shorten life and they tend to be well tolerated. There are Canadian guidelines out there. I was really uncomfortable with prescribing opioids for these types of patients early on. And so, often I was deferring to the family doctor on service. I was calling the palliative care team. One of the things I did a few years ago was I took a course through Palliative Canada called the LEAP course. So Learning Essentials, something advanced palliative care. I don't know exactly what the acronym stands for. It was phenomenal, though. I put a link at the end. If any of you are going to be managing these types of patients as an attending physician, I strongly recommend that course. And they go through sort of starting doses for opioids, how to titrate doses, how to calculate PRNs. And so this is just a little bit of what they taught me there. In terms of principles, use a short-acting opioid for breakthrough. Usually, by the time I'm using opioids, I'm not using any long-acting opioids anymore. Patients really aren't swallowing. I'm not treating kind of long-term chronic pain. I'm really treating pain in the short term in the last days of life. In general, your PRN dose that's available should be about 10% of the total scheduled daily dose you're prescribing, and it should be available every 1 to 2 hours. And you need to keep adjusting that as your baseline dose is going up to make sure that they're getting an adequate breakthrough dose. And so there's different strategies and ways that you can titrate opioids. Again, I'm not going to go through this in a ton of detail. I don't think a lot of you are going to be doing this in your practice, but it definitely is helpful to know sort of how to do this safely if you are. In terms of side effects, constipation, like I said, 100% of patients will get constipated. Make sure they're on a laxative. Nausea and drowsiness are also common. Usually, actually, that will improve within sort of 3 to 5 days of treatment. Patients will kind of become accustomed to those symptoms. But in the short term, you may have to manage them. There is no pre-established maximum dose for this population. You titrate until it's helping. If it's not helping, you might want to consider switching. So if there's no improvement at all in the pain control with increasing doses, or if there are intolerable side effects such as signs of neurotoxicity, you might want to look at rotating or switching to a different opioid. And here's just some directions on how to do that. Again, I won't go through that in detail, but it is kind of a little helpful tool that I've used a couple of times in these folks. Remembering that hydromorphone is 5 times more potent than morphine. And if you are switching from one opioid to another, you want to calculate the equivalent dose and start at least 20 to 30% lower on the new opioid, because cross tolerance is actually not 100%. And so they might only need a lower dose for safety of the new opioid. And so there's an example of how you can calculate that and how you calculate the breakthrough dose as well.
Do you know when you calculate the total daily dose, do you also check how many PRNs they're using and like incorporate that?
I do, yeah.
Okay.
Yeah, and that's sort of in the dose titration. So I look at the PRNs in the last 24 to 48 hours, and I kind of include that in the total daily dose from them. So Alberta Health Services, Covenant Health, which are the two main health authorities in Alberta, have developed wonderful order sets for care of the imminently dying. So those end of life patients. So again, it has check boxes of all of the different important things to consider. And it can be something that you guys can take a look at and reference if you're trying to kind of manage symptoms. Medications for comfort, for pain, for agitation, for respiratory symptoms and secretions. All of that has sort of some guidelines on places to start. So it can be really helpful tool for you to have a look at. And so that's it. I left myself a little bit of time. The key things I'm hoping you guys got out of this today, and I mean, some of it was hopefully not new information, but really that understanding that dementia is a terminal progressive illness. And I hope that a lot of you will start to use those words of brain failure with families, with colleagues, just to kind of reframe it in these circumstances where patients are getting towards the end of life. Recognizing that it's very important to have a focus on comfort, symptom management, and dignity in those last days. The assessment and management of these symptoms can be really challenging in this population. They can't report them themselves. But it's very important to kind of use structured tools, be aware that these may be potential problems for the patient, and look at ways to manage them to ensure that they're comfortable and well taken care of. Here's a couple of places that I've gotten most of my additional training. So that LEAP course is learning essential approaches to palliative care is LEAP. Palliative has some wonderful resources. They've got sort of a comprehensive LEAP course. They've got palliative care in long-term care facilities as well. For those of you who are going to consult there, we've got a great course for that. Their courses are all multidisciplinary. You take the course alongside family doctors, alongside nurse practitioners, social workers, rec therapists, and it can be a really nice community and some really good discussion in those courses. And I've also attended a few times the McGill International Palliative Care Congress that's every couple of years in Montreal. It's happening this year as well. They often have workshops on sort of pain and symptom management. Last 2 years ago, they had a course on sort of psychiatric palliative care. So it can be a really wonderful course. They also have a grand rounds monthly on palliative care. A lot of those topics are not the most applicable, but sometimes they are. So that can be a good resource as well. And here are some of my references and some different sort of sites to look at for tools and things. So that's it. Thank you. And yeah, I've left a few minutes for questions if anyone has anything or discussion points. Hopefully you found that helpful, even if this is not a patient population you're going to be working with directly.
Yeah, that was really helpful. Thank you. I appreciate that you included where you got more training because I similarly don't feel super confident around prescribing opioids, but it comes up a lot.
Yeah, that was the huge thing, that LEAP course, like exponentially increased my comfort level in the
Great.
opioid piece. Yeah.
Thanks.
Well, thank you so much. Feel free to reach out by email if anyone ever wanted to come and do an elective here on the inpatient units with these folks. I'm not always managing someone imminently at the end of life, but I am having these conversations regularly with family members. And it's a really sort of worthwhile population to work with and gain some experience with. So feel free to reach out. And thank you so much.
Thank you.
Have a good one.